And it's estimated that 709 million people in 2017 reported GERD symptoms. Yamasaki et al. In 2018, their paper noted that there was an increase in the total number of patients with GERD, which were more common in the younger population. And another study saw the greatest rise in patients between 30 and 39 years old, which is notable, and also that about a third of those people reported decreased work productivity. So we're spending a lot of money on PPIs, and we're losing money because we can't get to, we're not the best that we can be. There is also, some of the highlighted general characteristics, but really the limitation is that there's possibly lacking, it possibly lacked diversity. So it's kind of a busy, tiny slide, but it's basically FDA indications for PPI. I'm putting this up now because actually at the end of the talk, we should know the FDA indications for PPI, and we should be good stewards in making sure that we're using the medications correctly. So what's the trouble with the PPI and with PPIs and the data that we have? In looking at, in doing the literature search associated with this talk, I just got dizzy with what seemed to be thousands of articles. Every day there was something new, and seems like all systems of the body were associated. There is some association with some sort of dysregulation or some sort of disease associated with all parts of the body. But the problem is really most of them, if not all of them, really are observational meta-analyses, and we only really have one randomized clinical trial. So another busy slide, I apologize. So this was from 2011, paper by Dr. Sheen and Triadopoulos, and I had to say that several times. And it's really pretty busy, but the bottom line is it's not new that we've identified potential problems. But the bottom line is that a lot of the risk is theoretical, and really it remains that if you have a compelling medical reason, you have a conversation with the patient and you continue with the PPI. So again, in looking at all the data. I'm not a statistician. I know that I'm looking at a couple of MD PhDs who get this all the time, but I had to think, how do I separate the wheat from the chaff, right? So if I'm looking at 100 articles and there are lots of numbers, how do I stop being overwhelmed and step back? And so I thought, well, what's this odds ratio and relative risk? What does all that mean? Well, you know what it means. But basically for me, I had to figure out what it meant and whether an odds ratio of 1.1 is the same as an odds ratio of 9. It's not. But for me, knowing what those numbers meant, odds ratio, relative risk, absolute risk, was really key in trying to figure out what all this meant. And I apologize if it's bonehead, but I just kind of had to show you how I got there. In addition, you look at those numbers and really, what's it saying? And who's saying it? Are a lot of people saying it? And are they saying the same thing? How's the data presented? And does it make sense? So, does it make sense? So for example, I go onto the Golden Gate Bridge with a friend of mine, and he gets hit by a bike. So does that mean that 50% of the people who walk onto the Golden Gate Bridge will break a leg? I hope not. Same thing, there's a traffic light installed by my house. 4 people have been hit by a car the year prior, but in the 12 months after that, only 1 person's been hit. So is there a huge reduction in car accidents? And if there's only one thing that was changed, you have to look at other things. Was the driver drunk? Was the sun in his eyes? And does having my house in a certain spot have anything to do with it? And by the way, the source is the manufacturer of the lights, right? So you have to see who's writing it. And I think the odds ratio of 2 is actually wrong. I apologize. So the one RCT that we have comes out of the COMPASS trial by Dr. Moayedi et al. And basically, they did a 3x2 partial multifactorial double-blind trial of 17,000 people with stable cardiovascular disease and peripheral artery disease. And basically, it was either rivaroxaban, low dose, twice daily with aspirin, or low-dose rivaroxaban by itself or aspirin by itself with PPI and placebo. So basically, and so there was a follow-up at 1 month, 6 months, and every 6 months following, and it was 17,598 patients. And basically, there was no difference in composite outcome of cardiovascular death, MI, and stroke. So that's significant, that's real. And again, you can see the same data here reproduced. Then there's everything else. So in looking at C. diff, I picked 2 papers, and one is basically Trifin, was a systematic review and meta-analysis of PPI and risk of C. diff infection. It looked at 356,000 patients, and there was a combined odds ratio of about 2, which was statistically significant, but there was heterogeneity. So there's a lot of heterogeneity. Hafitz, the next year, basically followed up with, there is the previous meta-analyses suggest that patients who are on PPIs have a higher risk for C. diff infection, but there is heterogeneity, and they wanted to find out if the risk is the same for for different organisms. And I didn't write how many people are on there, and I apologize, but basically the pooled odds ratio is about 4 plus times, with increased association with Salmonella and Campylobacter. So is this real? There's probably something to it. It's consistent among a large number of people, but there's no causality. So for COVID risk, Dr. Almario in 2020 and Dr. Shea in 2020 asked whether hypochlorhydria associated with PPI use increases the risk for COVID in the community. And it was an online survey of 53,000 participants, and 6.4% had positive COVID testing, or had a positive COVID test, with an adjusted odds ratio of about 2.15 for daily PPI use versus 3.67 for BID use, with H2 blockers not increasing the risk. And this was presented at DDW just last month. It's a little bit busy. I don't know if you can see all that. But whoops. But basically, there's data reviewed from large commercial databases, and and it came out to 61 million people in the database, with about close to 10% having documented GERD. And what they found, this is all very busy, but what they found really was that female patients using PPIs had a higher risk of COVID, with an odds ratio of almost 10, compared to their male counterparts of just a little bit above 2, and it was statistically significant. For renal disease, I picked these 2 papers, and the first one was basically an adverse events reporting system, so it's data mining, and it showed about 3,000 patients using PPI and acute kidney injury versus, that should say CKD, I think, versus chronic kidney disease, and basically it showed that there might be an effect with a stronger association for CKD over AKI. And then Lazarus et al. Had a population-based cohort with 248,000 patients with showing that the PPI use was associated with CKD in all analyses, but twice daily PPI dosing was associated with a higher risk than once daily. So we have dose-related dose-related issues as well as dose-related issues. So there's probably something to it. It's consistent, large population. So what do you do with all of this? So in 2017, there's a guideline put out by the AGA, and basically it outlines, so in 2017, and basically it says that patients with known GERD and acid-related complications should take a PPI, and if you have Barrett's, you should take a PPI. But basically, we also want to make sure that we reevaluate whether patients should be on a PPI long-term. So, what else can we do? This came out in 2017. I just started, I was in the middle of working at Stanford, and it was kind of a really big deal because we talk about billions of dollars being spent on PPIs when, in actuality, anytime you put forth a therapeutic regimen, it should have behavioral issues addressed, so diet, exercise, instead of going to a pill first. So in the end, what do? I wish it was more satisfying. I wish I had Dr. Arain's talk, and it was very reassuring, and we know that these things are true. But in reality, it's not that satisfying. So probably there's a real signal for enteric infections as well as renal disease and COVID, but really we don't have anything that says this causes that. So again, we have to know what we're treating. We use the smallest effective dose. We have frank discussions with patients, and we have to make sure that any additional evaluation should be looked at. So that's it. Thank you.
I have a quick question, Josie. With your patients, what are the barriers to getting them off of PPIs, and how do those discussions go?
Actually, it's been the opposite recently. Patients are taking themselves off PPIs. I've never had so many patients tell me about esoteric side effects. I've had 4 patients in the last 2 months come off PPIs because they were fatigued or they were more depressed. So I actually have the opposite problem. People have been all too eager to come off the PPIs. But to answer your question, for those who I think should be on there or who want to be on the PPIs longer, I have a discussion about the theoretical risks, and then I tell them that we really have to try to get them to the lowest possible dose. And I see them at least annually, just to make sure that it still really is the best thing for them.
Patients with the current C. diff on PPI, should we take them off PPI?
Patient with recurrent C. diff and on PPI, I guess in my practice, I would ask myself if they really needed to be on a PPI. If they don't, they come off of it, or I try an H2 blocker. Yeah. Anybody else have a better answer? Well, let me backtrack. I look to see if there's another reason that they have C. diff repeatedly. Do they have UC? So a patient with UC who's having repeated bouts of C. diff on a PPI, I would not necessarily think about the PPI. I think, is he or she in a UC flare? So you try to look at whether there are other reasons for the C. diff, and if it's really just down to the PPI, then I discuss, is it really something that you need to be on? Can an H2 blocker or PRN medications be used instead? anybody else have anything better than that? Yes, sir. Yes,
Yeah.
Dr. Nat.
Hi. I mean, I can just share my thoughts on that because, we end up seeing a lot of patients referred for TIF because they want to get off of PPI. And I'm curious on your take that also. But, in terms of counseling patients for risks of PPI, I think most of the data is actually pretty poor. The odds ratios are low. And the expectation to actually be off of a PPI long term with any anti-reflux therapy with TIF or Nissen is not necessarily great either because there's a fair rate of recurrent PPI use with even surgical intervention. I mean, I think as far as data for complications, the data is actually, if anything, the best for C. diff infection. So that, I agree with that being a scenario where you would counsel either stopping or changing to an H2 blocker. But in your experience, how often are you seeing patients that are seeking intervention like surgery or endoscopic therapy because they don't want to be on a PPI anymore? And do you think it's worthwhile to pursue those interventions?
Ironically, you and I share one patient, and in whom that is the in which that's the case. She, did you know that when you asked me the question?
Well, I mean, I know we've had some common patients like that, and I do have to counsel them that, I think that in terms of TIF alone, that at 5 years, about 20 to 30% are back on a daily PPI, and half of patients are taking some PPI. Personally, I say, technically the data shows that their symptom control is still better. So if you're seeking intervention for symptom control, that's potentially a good reason. But if you're worried about PPI side effects, I can't really in good faith tell you should
Right.
have this procedure because you might end up back on a PPI.
Right, and that's actually what I say to them. I think the one person that I have who really wants surgery over PPIs is somebody who's concerned about her renal function. And despite repeated conversations and stability of her renal function for years, she's like, I really just don't want to do this. I have one kidney. And so a lot of that is very emotional for her. But for me, most people really don't want to go to surgery. They really push it and yeah, they don't want to go to surgery. So for me, in my experience, it's really uncommon. It's just that one patient who says, I really haven't tried everything I can try, but I want to have Dr. Nat take care of my TIF.
Yeah, we should talk after about that case. Thank you.
Regarding the recurrent C. diff, I recently had one with the recurrent C. diff, and she had occult blood in the stool, gastric bypass, so I scoped her, and so I scoped her because I want to do fecal transplant. And then I found fossa anastomosis large ulcer. So what I did the fecal transplant, and I put her on PPI. And I hope I'm doing the right thing.
I hope so too. Only time will tell. Maybe Dr. Nat can comment on that. Yes, sir.
There's been a lot of studies about the possible side effects or complications from long-term use of PPIs. Now, I'm going to flip it around. Are there any good studies about the detrimental, effects of withdrawing PPIs? Like there's been some studies that have shown that maybe some mortality, benefit on certain groups of populations. Has there been anything like that done? Because there's a lot of patients who are on PPIs for legitimate purposes, and then they're asking whether they can get themselves off of it. Could you comment on that?
And your question is whether there's been adverse events reported from actually withdrawing from the PPI? I don't actually think I can answer that question. I don't know. I'll open it up, but I don't think I can answer that question, and I don't think there are.
Like certain people with high risk, say ICU patients and all of those, risk for bleeding and peptic ulcer disease, Barrett's esophagus. Has there been any downstream, effects of people getting themselves off of PPIs?
Well, I mean, progression of the issue that you're treating. But as I said, I don't know that I can answer that question. Can anybody answer that question? I don't think I came across that data. Anything else?
I'm sure we all have anecdotes
Yeah.
of that, but.
Thank you, Dr. Dillon. Thank you so much for your kindness. Thank you.
All right, we were very close. Thank you, Josie. That was